Today, we're diving into a real-life medical mystery. It's a story that unfolds like a detective case, with two very different patients, a series of baffling clues, and a life-threatening condition at the heart of it all. So, let's put on our detective hats and start examining the evidence.
Our case begins with two men who, on the surface, couldn't be more different. We've got a 24-year-old, just getting started in life, and then we have a 70-year-old well into his retirement. But here's the strange part. They both walk into the emergency room with an almost identical and, frankly, terrifying list of symptoms. Fevers, crushing fatigue, and all these signs that their blood just isn't clotting right.
So this is the central question, isn't it? Their symptoms are our first big clue. They're pointing to something really serious brewing deep inside their bodies. But what is it? And is it even the same disease? Our investigation starts right now.
Okay, so in any investigation, you start where the evidence leads you. And here, all the signs are pointing to one place: the blood. It's the body's superhighway, and right now, it's flashing some major warning lights. Every good detective follows a process, and in medicine, it's a path that's paved with data. We've already done step one, analyzing the symptoms. Next, we move to the hard numbers, the blood tests. From there, we've got to go straight to the source, the bone marrow, to find the smoking gun. And only then, with all that evidence, can we reach our final verdict, the diagnosis.
The prime suspect in a case like this, it's almost always leukemia. The best way to think about it is to imagine your bone marrow as this busy factory that's supposed to produce all your blood cells. Well, in acute leukemia, that factory goes completely haywire. It just breaks. It stops making the healthy cells you need and starts pumping out millions and millions of defective, cancerous white blood cells that just take over and crowd everything else out.
And here it is, the hard evidence from our 24-year-old. These numbers are just wow. His hemoglobin, which carries oxygen, is way down. That totally explains the fatigue. His platelets, which you need for clotting, have absolutely crashed. That's why he's bruising and bleeding. And his white blood cell count? It's through the roof. But these aren't the good guys. They're the cancerous imposters taking over the system. Now check this out. We run the tests on our 70-year-old. And unbelievably, it's the exact same disastrous picture. Hemoglobin and platelets are in the basement, and that white cell count is sky high. The mystery just gets deeper. The lab reports from two completely different men are screaming the same thing. Their blood cell factory is in total catastrophic failure. So the blood tests confirm this is a true medical emergency, but they don't tell us exactly what broke inside the factory. To figure that out, we have to get a sample from the factory floor itself. It's time to look at the bone marrow.
All right, this next step, this is where the case breaks wide open. A single peek under the microscope at the bone marrow is going to tell us, once and for all, if these two patients are actually fighting the same war.
And there it is. Under the microscope, we find the critical clue. Our 24-year-old's marrow, it's flooded with these cancerous cells called lymphoblasts. But in our 70-year-old, the culprits are a totally different kind of cell, called myeloblasts. Even though they cause almost the same problems, they come from two completely different family trees of blood cells. This one clue solves the entire mystery. So, the final verdict is in. The 24-year-old has acute lymphoblastic leukemia, or ALL. The 70-year-old has acute myeloid leukemia, AML. They're two totally distinct diseases that just happen to look the same at first glance. We can even go deeper with genetic testing and find the specific mutations driving the cancers, a Philadelphia chromosome for the ALL and an FLT3 mutation for the AML. Okay, so we've identified two different enemies. That means we need two different battle plans. And with acute leukemia, there is absolutely no time to waste. The clock is ticking, and the goal is to fight back and fight back hard.
Now, despite all their differences, the opening move against both ALL and AML is the same. It's an all-out blitz called induction chemotherapy. The whole point is to wipe out as many of those cancerous cells as possible and give the bone marrow a chance to reset. But right after that first move, the plans diverge again. The specific chemo drugs are tailored to the disease. The patient with AML gets a classic hard-hitting combo known as 7+3. The patient with ALL, he gets a completely different cocktail of drugs, plus a targeted therapy called a TKI. That TKI is like a smart key, designed specifically to shut down the engine that his particular Philadelphia chromosome mutation is using to drive the cancer.
Now this all sounds incredibly intense, right? Which leads to a really fair question.
Why not, start with something a bit gentler? Why not just give them blood and platelet transfusions to fix the low numbers and just see what happens?
Well, the simple answer is that it would be a total disaster. Supportive care is kind of like bailing water out of a sinking ship without ever patching the giant hole in the bottom. Sure, it might manage the symptoms for a little while, but it does absolutely nothing to stop that broken factory from churning out more and more cancer cells. The disease would just keep getting worse, and remission would be completely out of the question.
Okay, so that leads to the next logical question. If the bone marrow factory is the thing that's broken, why not just get rid of it and replace it right away with a stem cell transplant?
A transplant is a massively powerful tool, but it's not the opening move. You can't just put a new factory down on a site that's still swarming with enemy forces. You absolutely have to use that induction chemotherapy first to clear out as much of the cancer as possible, to get the patient into remission. Only then, for patients who are at high risk of the cancer coming back, is a transplant considered. It's a way to consolidate the victory.
So after following all the clues, from the emergency room to the lab, from the microscope to the treatment plan, what are the really big lessons from this whole medical detective story?
So let's break it down. First, and most importantly, acute leukemia is always a medical emergency. Second, and this was the heart of our mystery, very similar symptoms can hide completely different diseases. Third, getting the right diagnosis isn't a guess, it's a careful, precise, step-by-step investigation. And finally, the only way to move forward is with aggressive treatment. The goal is to hit it hard, achieve remission, and give the patient a fighting chance.
And all of this brings us to one last, really fascinating question for the future. We saw how finding just one genetic marker, that Philadelphia chromosome, completely changed the treatment plan. So, as we get better and better at reading the tiny genetic clues that define these diseases, how much more precise can our plan of attack actually get? Are we heading towards a future where we move beyond these broad categories like ALL and AML altogether, and every single patient gets a treatment plan that's as unique as their own personal medical mystery?